before us, let's just take a breath and acknowledge what we are living through, the toll it's taking on people, work, families, and us as advocates. Our organization, NOLA, Northwest Health Law Advocates, is dedicated to improving access to healthcare and health for Washington residents. We use our voices to raise up the concerns and barriers that many in our state are facing when seeking to get and stay healthy, particularly those who are Black, Indigenous, immigrants, and people of color. Even in this financially uncertain era, and especially with the pandemic we're living through, we believe it's important to focus on becoming a healthier people and that everyone who lives here should be treated equitably. In this and upcoming sessions, you'll hear a number of perspectives on this theme. Today's session is Policing and Pandemics on Racism, Health, and Justice. I'm so pleased to introduce Dr. Rhea Boyd and Edwin Lindo. Dr. Boyd is a California-based pediatrician, public health advocate, and scholar who writes and teaches about the relationship between structural racism, inequity, and health. Among other roles, she's the Director of Equity and Justice for the California Children's Trust. Edwin Lindo, JD, is a critical race theory scholar. He interrogates racism in the systems of medicine, law, and society. He's currently acting assistant professor and assistant dean for social and health justice at the University of Washington School of Medicine. He hosts a podcast on health justice called The Praxis that explores the effects of racism on health. Check it out, it's great. More information about Rhea and Edwin is on our webinar webpage. But I'd just like to express my great appreciation for them to be here today. Rhea's going to present slides and then engage in a dialogue with Edwin. We'll have time for some questions at the end, so please enter them in the Q&A box and we'll get to as many as possible. Rhea?
Thank you so much for having me. It is an honor to be here and to speak alongside my homie and colleague, Edwin. Let me just share my screen so we can get started. I think that pause that you had us take is a really critical one because, as I had noted earlier this morning on Twitter, a lot is going on in 2020's America. Today, I'm going to talk about a slice of that, and we're specifically going to focus on the intersecting forms of violence that threaten and shorten Black lives, but really all of our lives. And we'll end with a beautiful conversation with Edwin about what that means for justice. I left my Twitter handle here. I think it's an easy way for folks to follow up with me if you have questions that we can't get to today. I don't have any disclosures, so let's jump in. Inequality is growing in the United States, and my home state of California leads the way, where the top 1% of earners earns more than the bottom 80%. This is in part because wage stagnation is profound in this country. If you look at hourly earnings for non-supervisory employees, folks who work but are not the boss, they are making essentially the same right now as they did in 1973. As a result, the purchasing power of our workforce has barely increased over the last 50 years. And the reality is that we are now a part of a generation for whom only half of our children will out-earn their parents. And economic intergenerational mobility is profoundly shaped by race and class in this country. This is data from Raj Chetty, who used to be at Stanford but is now at Harvard. And what it shows is if you look at the green map, it essentially pays to be a little white boy who grows up to be a white man in the United States. Because no matter where he lives, he is likely to earn more in adulthood than his parents did when he was a child. Conversely, if you look at the red and orange map, you see that there's nowhere safe to be a little Black boy who grows up to be a Black man in this country. Because virtually everywhere he lives, he is likely to earn less in adulthood than his parents did when he was a child. As the researchers summarized, in 99% of neighborhoods across this country, Black boys will earn less than white boys despite growing up in remarkably similar families. When I present this data, people often say they're not surprised because our nation's history of racism. And yet these families and little boys are so similar in so many ways. They both grow up in families with two parents. Their families have comparable incomes. It's not the racial income gap. They have comparable levels of education. It's not the achievement gap. They have comparable levels of wealth. It's not just the wealth gap. They live on the same city block and they go to the exact same school. It's not just residential segregation, which is a major driver of racial health inequities in this country. So what is it? What they found is that intergenerational economic mobility gaps are the smallest in parts of the country where there is low racial bias among white folks, where white people are less racist, and where there's high father presence in Black neighborhoods. This isn't father presence in your home. This is father presence on your city block. And so we have to ask ourselves, what's the connection between white folks' racism and father presence in Black neighborhoods? And we have to call into question even casual forms of white racism, like what the Root journalist Michael Harriot calls white collar crime, CALLER. When white folks call the police on Black folks just for existing in public, it not only invites potential intimidation, harassment, violence, arrest, incarceration on that individual, it also risks extracting Black fathers from Black communities, which the impact of that is intergenerational for the kids who live in that community, and particularly the little Black boys. So this is the pre-existing inequality that already was washing our nation when COVID-19 broached our shores. And if you overlap current places of COVID outbreaks, you see it maps closely to areas where there's a wide gap in intergenerational economic mobility. Among kids, we know that Latinx and Black kids are most affected. This is data that just came out this week that told us among school-age kids, kids 5 to 17, Latinx kids make up almost half of COVID cases. If we extend that age group to young adults, Latinx folks make up 43%, of confirmed cases. And among children, youth, and young adults age 5 to 29, Latinx populations make up almost half of COVID deaths. If we combine the deaths of Latinx populations with the deaths of Black populations, all who are younger than 21, it makes up 74% of COVID deaths. But most of the data that you hear about is about adults, for whom we know there are also enormous racial health inequities. This is data looking at just 50 million adults who only are in EPIC. Looking at those adults across the United States, we see that Black folks, Latinx populations, Asian populations, particularly Pacific Islanders, and Indigenous populations have higher rates of hospitalization and death from COVID. We also know that Indigenous populations are enormously affected, particularly in states like Mississippi for Choctaw Nation, and in states like New Mexico, Arizona, and Utah for Navajo Nation, where they make up the #1 population affected by COVID deaths. But if you compare Indigenous Americans to white Americans across the United States, their COVID death rate is 3.3 times as high. In total, though, Black Americans have the highest COVID mortality rate. It's 3 times that of Asians and 3.4 times that of white populations. If you look over time at what's happening to COVID death rates among communities of color, the inequities are widening. And so we have to ask ourselves, are these just simple differences in health, which we would call disparities, or are these inequities, which are differences in health that are completely preventable? And because they're preventable, they're unjust. Today, we're going to explore the extent to which these are inequities. So where do inequities come from? Health inequities arise when populations are made vulnerable. That's in red and in bold because no racial group is innately or biologically more vulnerable to COVID-19 than any other. They're made vulnerable. And that usually happens through the inequitable distribution of protections to keep folks from getting sick, and the inequitable distribution of supports to treat illness and ameliorate all of the consequences of being sick, like the economic burden we've seen accompanying COVID-19. So at the beginning of this pandemic, we said what would increase an individual's risk for having COVID-19 complications and early death are chronic underlying conditions like heart disease or diabetes, advanced age, and poverty. But what we didn't say, and we absolutely have to recognize, is how segregation profoundly shapes the racial distribution of who has heart disease in this country. How chronic discrimination increases rates of hypertension in communities of color. How environmental racism shapes whose air is clean and whose air is not, and contributes to asthma in communities of color. How the racial wealth gap profoundly concentrates poverty in communities of color. How toxic stress and chronic exposures that increase cortisol can increase one's allostatic load and thus weather or prematurely age your cells. This is how someone's cellular age could be advanced of your chronological age, and you could have complications and early death at much younger ages than previously recognized. These are all examples of how structural racism shapes who has COVID and who doesn't in our country. And it does that by offering differential access to goods, services, and opportunities by race. It reveals how inherited disadvantage, not just inherited disease, determines who's sick and who's well in this country. And that's a term from Kamara Jones, who is one of my favorite pediatricians. All of this illustrates how the physical and structural, the legal, policy, and cultural norm environment in which we all grow, learn, work, and play shapes not only our health, but the health of our kids and the health of our kids' kids. So when we talk about the inequitable risk for COVID, and I put a star by risk to remind us, we're thinking at the population level about systematic drivers that shape outcomes for groups, not at the individual level where individual behaviors might shape individual outcomes. At the population level, the risk for COVID is absolutely not well summarized by words like poverty or words like underlying illness. Instead, that risk reveals legacies and current practices right now of racial exclusion, discrimination, disinvestment, and violence that concentrates disadvantage in communities of color, creates adversity for children of color, and shapes our population level opportunity to be well and provides the perfect conditions for communities of color to be sick. These are the factors that are why all-cause mortality is increasing in this country, driven by an increase in Black and Indigenous mortality, but also by an increase in mortality rates for white folks. As a result of that increasing mortality, life expectancy is decreasing in the United States, and it has been since 2014. This is an aberration for any wealthy nation in the world, and especially the one that spends more on healthcare than any other. And so despite the enormous toll that COVID-19 is taking on mortality rates, white mortality is still likely to be less right now than Black mortality has ever been every year that we have data. This is a map that I took from New York Times that cited data by Elizabeth Wrigley-Field. And as you can see, that jump in projected white mortality is still below the baseline Black mortality in this country. And this chart doesn't even chart Black mortality from COVID-19, and it doesn't even include Indigenous mortality pre or post COVID-19, which is likely above that of Black populations. I show this because it's so devastating. And it's as Elizabeth Wrigley-Field said, racial inequality is as deadly as COVID-19, because in this year, right now, white life expectancy will remain higher than Black life expectancy has ever been in the middle of one of the most deadly pandemics in the last 100 years. And so we have to ask ourselves, what are those legacies and practices that are driving this enormous gap? When we think of that time, we often think back to the Jim Crow South and segregated public accommodations like water fountains or bus depots. But we don't as often think of this time. This is a picture of Newark, New Jersey in 1967 in what historians now call the long hot summer of 1967. They call it the long hot summer because during that summer, there were 169 race massacres across the United States, all sparked by an event of police violence against a Black taxi driver in Newark, New Jersey. What we don't talk about when we talk about the uneven distribution of disease and premature death in our country is what it feels like to be this little Black boy walking down your own city block with your own government at your back. That's the National Guard with their guns drawn, and your hands are up because you know you're not safe. What we don't talk about is what it's like to be these Black women who also have their hands up and are lining the sidewalk and not intervening because they also don't feel safe. Or what it's like to be that little Black boy who's looking back at a boy who's just a little bit older than he is, and he's understanding something specific about what it means to be Black and a boy in the nation of his birth. What we don't talk about is the way that state-sanctioned violence absolutely shapes the distribution of disease in this country. And we don't talk about how little has changed since that long, hot summer. This is a Pulitzer Prize-winning photo by Devin Allen that covered Time magazine in 2015 after police killed Freddie Gray in Baltimore. And he asked the app question, how much has changed? And past what has happened to George Floyd and Breonna Taylor and Elijah McClain, we continue to ask what has changed. So when we talk about the factors that are increasing rates of COVID-19 in communities of color, we absolutely have to talk about police violence. What do we know about police violence? We know about 1,000 people are killed by police every year in this country, and it's a particularly deadly exposure for Black men and boys, of whom 1 in 1,000 will be killed by police in their lifetime. I always give that figure to pediatricians because 1 in 1,000 is also the mortality rate of measles. When you think about the near constant public health surveillance and investment we all put as a society into eradicating measles, you begin to see the ways that racism shapes not only Black folks' risk for premature death, but also shapes our public health responses as well. This is data from my state of California because we are lucky to have an open justice portal and we mandate that police report use of force and then make that publicly available through our open justice portal. What we know is that just last year when police used force, 1 out of 5 times somebody died. That's usually what gets picked up in the media. But what's much more common actually is serious bodily injury that happens nearly 2 out of 3 times. So then we have to ask, well, why did police come to the scene in the first place when they used force? And this is devastating. They came to the scene when they used force almost half of the time because somebody called for help. Just think about that. Somebody called for help, police used force, and 1 out of 5 times, somebody's gonna die. And almost 2 out of 3, somebody's gonna suffer a serious bodily injury. This is why advocates, abolitions, parents, Black folks, and a multiracial uprising is taking place to say, we can no longer call that institution one that keeps us all safe in the same ways. We also, here in California, are lucky to live in a state that is now transforming who you call when you need help. This is an act that just had near unanimous support and was passed and is awaiting signage by our governor if people are interested in policy solutions that could exist in your state of Massachusetts. We also have to think about populations whose exposure to police are shaped by their immigration status. For kids in particular, experiencing or witnessing an immigration-related arrest contributes to depression, and those symptoms are magnified if both of their parents are undocumented. For kids who don't even witness that police violence and aren't direct victims, they may also experience it as caregiver absence or a custody transition or their own criminalization or that of their peers. And that's what associates even routine police encounters with exposures that create feelings of loss or stress in kids. And that's how it can also affect kids' health, even if they're not present. Ultimately, the violence of policing separates children from the social networks on which they rely and in which they thrive. And the violence of racism and the many inequalities racism creates at a population level impairs and disappears caregivers. Racism is a devastating root of undertreated disease and completely preventable death in this country. And in short, it kills people. But we know equality, equal access to rights and resources can save people's lives. And that's why people like Edwin and myself have been shouting from the rooftops that protest is a powerful and vital public health intervention. It is not just a constitutional right, it is also a public health intervention because it helps to increase equality in society. And yet we live in a society where not everyone's protesting the same thing. This is a headline from the Los Angeles Times looking across the country at state house lawns as predominantly white populations took to them to protest public health advisements. This means we also have to ask questions about how whiteness and an investment in political advantage can actually disadvantage and harm white folks too. So briefly, we're going to talk about whiteness because whiteness is shaping all of our access to resources and rights, but we don't talk about it. So what is whiteness? It's different than white. White is a racial status that is based on someone's perceived skin tone. Whiteness is a structural apparatus that affords that racial status certain privileges or advantages through laws and norms that empower, normalize, favor, and reward white people as a population. I underline as a population because individual white folks can absolutely face hardships, and they do. But as a population, white folks benefit from the advantages that whiteness offers them. One example of that is we know compared to white folks, Black folks have less wealth at every level of income. And compared to white folks, Black folks have less opportunities for employment at every level of education. Those are examples of how whiteness can be a boost above your income level or your education for wealth and employment in ways that it is not for other communities of color, and particularly for Black folks. Jonathan Metzl wrote this book in 2019 that I have used to learn more about how whiteness works in society, and I would highly recommend it. Full disclosure, I reviewed this book for The Lancet, which is a medical journal, in January of this year. But I'll just leave you with his argument because it really is compelling. What he says is that the structural racism that whiteness engenders at a population level creates a scarcity of resources that also harms and impairs white folks' health and sometimes leads to the premature death of white folks too, in the same way that it does for other communities of color. And so to adequately respond at scale to racism as the public health crisis that it is for Black folks, for Indigenous folks, for communities of color, and for white folks, we must move towards abolition. We must move to abolish racism from every institution, every practice, every policy, and every social norm in which it operates and too often hides. The future health and well-being of our kids and our kids' kids will absolutely be measured by how well we succeed in this. This is the last slide. We are approaching one of the most important elections in my lifetime and perhaps in your lifetime as well. And people are trying to steal our hope. So I want to close with the words of Bryan Stevenson, who is the co-founder and leader of the Equal Justice Initiative and really just one of our national treasures. As he said, hope is our superpower. Don't let anybody or anything make you hopeless. Hope is the enemy of injustice. Hope is what will get us to vote, even as people try to snatch that right from us. So I'm going to stop sharing here. Welcome Edwin on. I'm so excited to talk more.
Oops, my mic got moved. Well, thank you for that extraordinary presentation, Rhea. You've just brought home the information that's so compelling about the impact of structural racism, and really appreciate your pulling all that together. The slides will be available, by the way, to everybody attending today. I realized I didn't introduce myself. My name is Janet Barron, and I'm the director of Northwest Health Law Advocates. So a little belatedly, just wanted to throw that in, and then throw this open for discussion between Rhea and Edwin to talk about the implications of the information that Rhea presented, and some reflections on how these impacts on health are playing out, especially in our communities in Washington State. So take it away, Rhea and Edwin.
Rhea, let's talk about California, because I'm born and raised in the Mission District, and we see what's happening in the heart of the Mission, but that's true for many cities throughout the state. And there's a lot of folks, I remember reading the papers that say, well, there's these disparities with COVID. Maybe there's something about Black people and brown people that is causing them to have higher rates of mortality. What do we say to those folks?
I'm so glad you brought that up. So Edwin and I actually co-authored an entire article just to take down that very idea that ran in Health Affairs earlier this year. It's called On Racism, and it basically is challenging the idea that there is a biological or genetic reason for the health inequities we see emerging amid COVID-19. Like, let us just stay with a resounding no, there is not. That's absolute trash. Race is a social construct. We all make race, and we make race and maintain race all the time. But racism is what attributes different biological consequences to different racial groups. And so we as a field in healthcare have to tighten up, because there are too many articles that have run just post COVID-19 that have tried to attribute those inequities to racial groups when it's really racism. And so I'm so glad you highlighted that and our work together on it.
Yeah, no, I'm glad we wrote that piece, and it was an amazing squad of people that we wrote that with. And one thing, I think yesterday was the first time someone quoted me and made me a meme for a social justice endeavor, and it said, "Racism is the risk factor, not race. So that means our job is to dismantle racism if we are to cure our community." And when we sit with that, it hurts. Most of the folks here are lawyers, but physicians struggle with the idea that there's something outside of the body that is affecting it, right? We want to solve it right then and there. And it takes me back to your slide about abolition. I think, I don't know if we were on the AMA presentation, or maybe, I think it might have been us, but we said abolition on one of the largest medical platforms in the country. And many people freeze when they hear that word, right? And I want us to be clear that we're talking about the clear articulated theoretical approach of abolition, which many people practice already, right? When you think of physicians, the goal is to abolish the disease, right? You don't say, well, let me try to just get half of it out if you're a surgeon, or let me try to just solve part of the, you say, we want to make you healthy 100%. But similarly, on policing in communities, which is the next part of our conversation, there's people who already live in communities where police don't exist. Right here in Seattle alone, and we've said this before, and it's true for many cities, there are neighborhoods where police are not roaming the streets. They don't sit in their squad car looking out for people to come out of their house. But that is true in the south end of Seattle on Rainier Avenue. That's true in the Mission District. That's true on Crenshaw, right? Where that the police have made it their backyard. And so the question is it really a radical idea, or is it that it's radical because it actually works if we applied it to everyone? So I hope it's something that we wrestle with. Another thought I want to bring up, speaking of policing, is this thought of in custody care. Can we talk more about that? And I'd love to hear your thoughts.
Absolutely. I'll try to link those two together. And I'm seeing the comments too, where people are saying that was a lot. I know. I ran through that so fast so I could get to this conversation with Edwin. I think they'll make the recording available so folks can slow it down, and we'll absolutely share the slides. So don't worry. Abolition. A lot of people are choking on that word right now. And I honestly think when we choke on the word abolition, what we're choking on is our own reliance on the structures that harm people. I'll give an example from, in custody care. Like when folks are in custody, they're incarcerated and they need healthcare, and they have to come to a healthcare facility where all the rest of us are. They often are under direct surveillance of an officer, and they sometimes will spend their entire hospitalization shackled to their bed, right? Also, we have police officers who often line our emergency rooms, are just a phone call away from any dispute with a patient, and have, in certain cases, physically injured patients and sometimes shot and killed patients within hospitals or just outside hospital doors. So I bring that up to say, I think in healthcare, we choke on the word abolition because we rely on the violence that police can bring to respond to violence that we either fear or that we have happening in our own hospital. People say, well, we can't get rid of police. What about violence of patients against, our staff? Or what about the incarcerated person attacking the rest of the staff? That's why we have to put them into shackles. But what abolition would call us to say is, we're a caring economy. We are supposed to be a caring infrastructure. And if we can't sit in relationship with people that we are seeking to care for without inviting violence on them when they invite it on us, if we can't respond to violence with something different than violence in a caring infrastructure, there's no hope for it to exist anywhere else. It has to live in hospitals first.
Right.
And after that, I would say schools. So I'm a huge proponent of police-free hospitals and police-free schools. To end that surveillance, to end our reliance on this punitive, violent infrastructure that would also force a shifting of how we orient to patients.
Yep. Yeah, I remember to expand on it a little bit. Most folks won't believe it, but the carceral system heavily relies on the medical system to be its cousin in this process of criminalizing our communities. I say that because I remember speaking to a trauma surgeon, and he gets asked to speak as a witness a number of cases. And the prosecutor comes to him and asks him to actually speak about not the care of the patient, but of things outside of the care that he provided. And his response was, I don't want to talk about those things. I don't feel comfortable talking about those things. I am their provider and I can speak about the care I provided, and that's it. And the prosecutor's response was, you don't understand. Your job is to help us put the bad guys in jail. When that's the mentality that the carceral system has, it gets to reach into the walls and the halls of any system that we hold. It's no longer separate. It is now lockstep, an element and variable of the carceral system. And if we allow that to happen, I mean, there's women who are pregnant that come into the OBGYN clinics or to get care that are shackled to the bed, right? This is completely absurd that the hospital has now become an extension of a jail.
I'm so glad you got into that, because this is, I think, why we don't want to move towards abolition. Like, I can name another example just from pediatricians and other mandated reporters, which would also include, teachers. We also, when we feel uncomfortable or we technically are supposed to be worrying about the safety of a child, we extend the carceral gaze into that child's life by referring families to CPS or Child Protective Services. The vast majority, 80% of referrals to Child Protective Services are for neglect. 90% of what drives neglect is lack of material resources, right? Concentrated poverty that we kind of went through, how that intergenerationally lives in communities of color, particularly Black communities. As a result of those referrals for neglect, by age 18, 1 out of every 2 Black children will have been referred to CPS for an investigation. 1 out of every 2, right? Like, that is increasing the carceral gaze into kids' lives before they've even been in public, before they've made any choices. They're already being partially surveilled. They're already within the system. And that's on us in healthcare for making that linkage. And there are many, Dorothy Roberts, there are so many folks who are calling for a reordering of the child welfare system, such that we don't ask caring providers to be the ones that invite that, the carceral system into people's lives.
Yep, absolutely. And to expand a bit, the numbers disproportionately, when we look at CPS and pediatrics, CPS is called overwhelmingly on Black and brown families for the exact reason you're mentioning, right? The lack of material wealth, the materiality of being able to say, you know what, we have everything we need. When we talk about crime, and some people say, geez, they're talking about policing and crime a lot. And I thought they were in medicine. And what we're trying to belabor here is that they unfortunately are inextricably bound. And it is now our job to find ways to disabuse ourselves of that relationship, because we think we're reliant on it, right? That if we're a county hospital, then we have to be lockstep and in support of the county, regardless of the element that it is prosecutor's office, policing. And what I want to encourage folks is to look at how do we advocate to say, no, the hospital should be an autonomous zone, a place free where people can walk in and say, I seek care because I can't afford it anywhere because you are the county hospital for us. That walk in and know that they're not going to be scared that they get arrested in the waiting room while they're waiting for their diabetes care or for an emergency that they have, because it happens. People getting arrested in the waiting room is so absurd to me. It is the antithesis of care. And how do we fundamentally reimagine, like Rhea said, what that looks like? I think that's the work we have to do. We have to be the creatives, but taking the information, or not taking the information, but taking guidance from the community. Because as we know, and Rhea says all the time, those closest to the issues are the ones that are closest to the answer. And we must be the facilitators because we have the resources to help build that vision that these communities and our communities have.
Yes to that, times a million. I'll also add some language that I've been borrowing from a Harvard historian, Leah Wright-Rigueur, who on a podcast, who knows how many, what is time these days? Earlier in this pandemic, she said, Black people live without sanctuary in the United States. And I've been sitting with that and sitting with that and sitting with that. And it's so real. Black folks live without sanctuary on the sidewalk, right? Because white folks will call the police on you just for being out there. Without sanctuary in our own homes, Breonna Taylor. Without sanctuary in our hospitals when we're trying to seek medical care. Without sanctuaries in our schools when our kids are just trying to learn. Like, there is literally nowhere Black folks can go. Not our cars, Philando Castile, not the park, Tamir, when you're just playing with a toy. Like, there is nowhere. And if there's nowhere, if we want to call ourselves advocates, I think we have to become architects of sanctuary. And the map to build sanctuary is abolition.
Absolutely. And for the other lawyers in the room, I'm going to try to connect another dot, which is around human rights. And if we aren't talking about the issues and the continued oppression of Black folks and Indigenous folks as human rights violations, then we don't see the severity that is occurring in our own backyard. Because if we go to the Geneva Convention of Human Rights Violations, if we go more specifically to refugee status is outlined and articulated by saying that you can have racial refugee status, that there could be people who are scared for their lives because of racial persecution. By definition, this country is creating racial refugees within its own borders in the Black people in our communities. And yet we're not doing anything about it. We feel like we have to go to some other country to find the terrible things that are occurring. And the truth is, it's happening right now. If a Black person went to the border of Canada and said, I'm seeking refugee status, they would be hard pressed to say no. The data tells us, Rhea told us, 1 in 1,000 Black men will die of policing. They've cured measles, and we still haven't found a way to cure this pandemic that is killing our Black brothers and sisters. And we have to contextualize it in its true severity, that we are living in a war-torn country that has been built on the backs of Black people, and it practices racism on Black people. And everyone else is seeing the vestiges and the residue of that racism, and is now our time to say, I'm not taking it anymore. But you have to use every leverage you have, the legal minds. There should be a lawsuit that says, we will not stand in a country that is committing human rights violations, and we will fight until that gets addressed. And I'm not coming up with the idea. We're talking way back to a lawyer called Peterson, I forgot his first name, who filed a petition to the Geneva Convention saying the US is committing genocide against Black people. And he outlined every case of state-sanctioned violence. And he never got a chance to speak on it, but he did sit on a panel. And the first lady was in that panel. When asked by a media person, well, what did you think of his case? She said, he's not wrong. Right. So how do we look to the history to inform what it is that we do today? Because it's there.
I love you lifting that up. If I could just say one more thing, just to lift up Black women, because just today I wrote an article in The Nation that tried to honor all of the Black women who have tried to do this, because to your point about the people who are closest to the problem have the solutions. Like, in the face of all of what we have outlined, Black folks, Indigenous folks, folks of color, Pacific Islanders, folks have been doing the work. And to just highlight one example of Black women alerting the world to human rights abuses, you know, we got to say the name Dawn Wooten right now, right? Dawn Wooten, the nurse from that private detention facility in Georgia, just told the world of those forced hysterectomies, of actual active genocide in the United States right now in a state-sanctioned facility, right? Like, she risked her reputation, her career. She put everything on the line to do that. And she did that. You know, some people came out and said, well, why is she working in a nice facility? You know why Black women like Dawn Wooten work in a nice facility? As we learned from Monica Miclemore, who I would highly recommend people follow on Twitter.
Yes.
It's because of all of the barriers to women actually who are Black women nurses getting jobs, to them becoming, you know, licensed RNs. Like, there are so many barriers to that. There are only so many places where some Black women can work. And so, one, we never want to look down on people who are doing the work, because working in an ICE facility is serving folks. But then also to highlight the fact that even in her own precarity in that working environment, she still risked it all without a book deal, without waiting for all of the money, right, to let people know that what was happening to those women right now is an atrocity.
That's absolutely right. And it's time and time again that Black women have led the way, that have spoke up, that have, I mean, think of Ida B. Wells, who risked her life documenting the hangings around the country, knowing that that investigation was going to put her life at risk, right? And that happens, I mean, every time we turn. And so I appreciate you bringing that up, because it is our responsibility to not just say we should listen, but to uplift, to say, this is how we should be led. This is how we should move. And I know we've talked about a lot of different things, but I want folks to realize, like, this is what we do on a regular basis, because our lives and our community lives depend on it. We have to sharpen our analysis. We have to get stronger with it, because the truth is, the current president of this United States would love it that this conversation never happened. I'm looking at the executive order right now. The executive order says that you cannot talk about white privilege, that critical race theory is un-American, that critiquing the United States shouldn't be something that we get trained on. And the truth is that I frame it this way. If our current president believes that racism is inherently bound to the identity of being an American, then yes, that is my job to dismantle it. That we need to find a different type of America that doesn't hold racism as its key value and the key driver to extort capital and labor. But we're now in a place where our federal government, in effect, is creating a red fear like they did in the 50s, suggesting that we are un-American, a proxy for effectively saying your melanin is too dark for you to be here, and we're not happy with the way you're behaving, so you either straighten up or we're going to take your money. Right? That's a terrifying place to be in. Terrifying place. And for everyone else, if they're willing to do it with us, that means they're willing to do it with you. And so we have to stop it now.
Oh, please get into that. I mean, it's part of why I've now started presenting also on whiteness more fervently, because it's so important that people understand that what we're up against isn't just what's going to kill Black folks and Indigenous folks and Latinx folks and immigrants. It's going to get us all. And COVID-19 has been the perfect example of that. You know, while and I think it's like right now, 1 in 1,020 Black folks have died just of COVID-19. 1 in 2,000 white folks have died. More than 80,000 white people have died, right? Like, everybody gets got in a system that doesn't honor human life. And when you try to devalue Black folks, you devalue and debase yourself, and you take resources that you need and out of your kids' mouths. And that's what I think the administration doesn't want people to know, and specifically doesn't want white folks to know.
Yeah, I see a comment here. It says, are you having these conversations with law enforcement? They need to hear you. Many people on this webinar are concerned about this. You're preaching to the choir. We need experts like you to talk to those in policing. Well, I'll say this. I've never been invited to a law enforcement conference. Let's be very clear. And that's not an accident, right? Like the perpetuation of white supremacy is not going to allow someone to critique it in its face. And that's the same reason Rhea showed her slide that says, I have no conflicts. I use that slide and I make fun of it because I'm like, I don't think I'll ever have a conflict because I don't get money to dismantle racism like that. There is no grant for that. Believe me, I get the NIH weekly grant submission RFPs, and it says, we'd love for you to research the disparities in communities. There is no element of that grant that says, and we'd like you to guide us in how we dismantle it. And so the question I always have is, well, who is that left to? I don't know. It's usually left to the folks with the least amount of resources, having to fend for themselves, to come up with their own COVID testing, to try to find ways to protect themselves. We really need a true transfer of resources and power, because our communities they keep telling us what they need. And we keep saying as an institution, well, clearly you don't know what you're talking about because you don't have a PhD, or you're not educated, or you're not smart enough. And I'm saying, no, I call BS. And I call it very loudly, because the things I'm telling you now is because I learned it from our community. Organizing in San Francisco against police brutality, against gentrification, folks saying that, why are you hanging out with those people? And I'm like, because those are my people, right? How do we reframe what it means? Yes, we have law degrees and MDs. The elder told me once, look, Edwin, it's great that you went to law school, but those letters after your name is just a skill. No different than the person who takes care of the babies, that cooks the food. And when we need that skill, we'll tap on you. Until then, shut the hell up and sit down. And I learned a whole lot. And I'm grateful that elder did that to me.
You know, if I could say one thing before we take this break, is that Black Lives Matters is a conversation with law enforcement, and it's a conversation with society, because one, law enforcement doesn't invite us right into their offices. We talk to them at open comment during board of supervisor meetings in, cities and counties across the country. But when people take to the streets, that is a conversation with law enforcement, and we have to see it in that way. And it has been the most successful, and as the New York Times recently told us, the largest movement to do so in our nation's history. The question is, how are law enforcement responding to that conversation? And in cities like yours and cities like mine, we've seen it.
Well, this has been an important, very powerful, thought-provoking discussion. Thank you both. We wanted to give people listening today a chance to ask questions. And so we'll take a very brief break while we collect them. Please put your questions in the Q&A. That is, you can also put them in the chat, but it would be easier for us to select based on the Q&A. We're not sure we'll have time for all the questions, but we want to get to as many as we can. So hang tight for about a minute, look at this beautiful picture, and then we'll be back very shortly. Okay, of course, whoops, we can't. Okay, we are back with a few questions to prompt a little more discussion. Just wanted to start with something going back to the pandemic that we are all in. And during this pandemic, the economy has suffered and governments are financially strapped. Washington State's considering cutbacks in public programs, including Medicaid, yet people of color and immigrants are disproportionately affected by COVID-19. So in this environment, how can the state focus on achieving equity in healthcare in the face of very limited resources? Would either of you like to start out with a response?
I can jump in. Sorry. Two quick things. One, we have to question whether resources are limited, frankly. I think that scarcity mindset is part of what comes out of a white supremacist frame, that only certain people should have things. There are a number of frames that have that, right? Xenophobia has it, Islamophobia has it, hate against folks because of their gender or their sexual orientation has it. The idea that only certain people should have things evolves from a frame of scarcity. And we in this country are one of the most wealthy in the world, and we print our own money. So the idea that we couldn't have more resources is not true. We could have more resources, and we could redistribute the enormous resources we have by taxing wealthy people and by allowing cities' debt to work a little bit differently, which is also an area I've been reading more and more about, which is how debt undergirds racial inequality. The researcher there, and I'll put their name in the chat, is Destin Jenkins at University of Chicago, who wrote in the Washington Post on that recently. So one, I don't think we have scarcity. I think we need to redistribute resources, and then that would help us address even what's happening right now.
Yeah, I would just echo that during this pandemic, which people say is the highest point of austerity that we've seen, somehow money for equity work is popping up. And when we were in the moment of abundance, it was, well, I don't know if we can do that work. I don't know if we can pull the budget to do that. The thing I always say, I would ask the nonprofits, I would ask our elected officials, the only thing that I believe that is a priority is the thing that I see as a line item in your budget. If it isn't there, then I don't care what we say is our priority. If there isn't money allocated to it, it is not a priority. And that's the work that Decriminalize Seattle has been working on. King County Equity Now, moving to the budget and saying we will reallocate funds from policing into community research, which I've been a part of, others I know have been part of, getting people paid on the ground, grandmothers, aunties, 16-year-olds, formerly incarcerated, getting paid to do community research of asking the question, how do we create a safe community without policing? Right? That's a beautiful reimagination. And so, yeah, I want to echo that we're talking about false scarcity here. It doesn't actually exist. The question that I have of what exists is there the political will to do it? That's always the question that we have in the community is, are you actually willing to do it? And we've been proven time and time again that the answer is no. But like Rhea said, the negotiation, the conversation is in the streets. And the more people that get in the streets, the clearer the conversation becomes. And I think that's what's gonna happen unless our institution fundamentally changes. And for all the legal scholars out there, I'm gonna throw another curveball for you all. But I actually think, and I got confirmation from my former con law professor that they agree, that we need a new constitutional convention because our constitution is not durable enough to withstand the absurdity that we're seeing right now. And it can't withstand the racism, homophobia. It perpetuates it. And so we need to reimagine even what this country looks like. And that also includes the economic system.
Thank you. We have time for just one more question now. And I'm going to take the one from Fatia Abdi, who says, thank you so much for an honest conversation. I would love to know what brings you both joy. And I think that's a great note to end on, although we do have, of course, many questions and want to continue the dialogue. But let's try that and we'll we'll wrap
Rhea,
up right afterwards.
take that one. It's a great question. Okay. What brings joy? Well, we have a 3-year-old. Her name is Estela, and Estela has her own library in South Beacon Hill called Estelita's Library, which is a social justice radical library for the community. And we are actually getting a new space. It's space that we own, land that we own. And so what brings us joy, brings me joy, is finding ways to decentralize knowledge that I had to pay an immense amount of money for, that is intentionally kept from our communities, and stealing it and giving it back to our community so that they could always have access to it.
I love that so much. I can't wait when I visit Estelita's library. I think what brings me joy is being in relationship, is getting to have this conversation with Edwin, who we are intellectual colleagues and peers, but also like friends trying to just build and be free in this world together. My relationships with my family. I think for all of us right now, the pandemic has likely highlighted the importance of human connection. And I feel most joy when I'm loved and connected. I'll also briefly say to some of these questions, care not cops, please look at divestment. And if there's something that we all could be doing, I think it's looking at yourself. I don't think Edwin and I sit up here trying to preach to y'all or trying to say we got it right. I think as I learn, I continue to change. And 2 years ago, I didn't have the word abolition in my mouth, and I didn't have a book on abolition in my house. You know, like as you learn, you move and grow. And I think that's what we as a field have to do together.
Wonderful words. Thank you so much, Rhea and Edwin, for this really enlightening and thought-provoking presentation and stimulating discussion. I know we weren't able to answer all questions. Feel free to email me at NOLA, Janet at NOHLA, if your questions were not answered, and I can distribute those. If you enjoyed this session, join us again next week when we'll have an update on legal and policy developments from Emily Bryce, NOLA's senior attorney and policy advisor, including what's going on with the healthcare repeal lawsuit. Seems like it's moving in the other direction from what we've been talking about. There's going to be a hearing, as you probably know, by the Supreme Court on November 10th. Emily will be followed by a panel of people working at state agencies discussing how policies and practices have changed during the pandemic. Should be a really fascinating discussion. Then our third session, the following Friday, will be about re-envisioning health equity in a post-pandemic world. Followed by the following week, session on COVID and behavioral health. And then finally, the last one is on older individuals and persons with disabilities, looking at the impact of COVID and systemic approaches. There's still time to sign up for those sessions. Every Friday this month, they'll start at 11:30 for 2 hours. And for lawyers, continuing legal education credit will be available for all 4 of those sessions. If you signed up for the series or any future webinars, please mark your calendar and you will receive invitations for those sessions by this coming Tuesday. And shameless plug, please consider supporting NOLA's work. We are in this struggle and looking forward to following some of the advice and coming up with creative advocacy approaches that based on what we've heard today and many other areas in the health system that we think need to be addressed. We engage in a range of advocacy and appreciate donations, no matter how small. Visit our website to find out more. You will be getting some follow-up information about this event, including Rhea's slides and a link to the recording. So please share it. We want this information to be spread widely. And thank you again for participating today, to our panelists and to all who attended, and to everyone on the NOLA staff and board who helped out with figuring out how to do this webinar. We're always looking for tips and how to improve. So if you have any feedback, please let us know. Thanks so much. So long, everyone.
Thanks, everyone. Janet, thank you. I have to run. Rhea, big hug.
You,
so appreciate it.
Thanks, everyone.
Bye.
Bye.